Yeah. Okay. So, see, all of you know now that the ECMO is a temporary cardiopulmonary supports. It's reversible for reversible cardiopulmonary failure. It's type of a mechanical assist device and basically made to give rest to the heart and to the lungs and to sustain life. So it is essential. One should know the weapon before it's using. So you should know the ECMO physiology in detail so that you can use it in the better way and in the safer way. So what I'm going to discuss in next 20 minutes is the physiology of extracorporeal circuits, the physiological changes that takes place because of extracorporeal life supports. So that includes the blood surface interaction with the circuit, the physiology of the circulation and the ACLS hemodynamics, and the physiology of gas exchange. So what are the components which we use in extracorporeal circuit is the cannula, the tubings, the length of the tubings, the diameters, and the material used that is going to affect the physiology of to the patient. We use a pump, centrifugal. Usually we use centrifugal pump. We don't use roller pump. But again, that can have an effect on the patient. Oxygenator, hollow fibers versus PMP with silicone. The one which we use right now commonly in ECMO is the PMP oxygenator. And how much the priming volume of the circuits and what are the fluids we are going to use. So all that is going to affect the physiology. So basically circuit physiology, the tube, it determines the resistance, the priming volume and the surface reactions, and that is directly proportional to the tube length. So if the tube length is more, it will increase the resistance, it will increase the priming volume, and it will increase the surface reactions. So that thing you have to always keep in mind. So if you have unnecessary too long a tube, it is going to create you a problem. Coated versus non-coated circuits. Coated circuits will have a less of surface reactions, while non-coated circuits will have more reactions. Coated circuits, you can think about heparin, low heparin or heparin-free ECMOs for some more time. While in non-coated, the circuits, the heparin-free ECMO is going to be a little difficult. But definitely there is no study which suggests whether it has got a prolonged or better outcome. Then about the pump, when we are using a centrifugal pump, it is preload and afterload dependent pump. So roller pump is usually not preload and afterload dependent, but the centrifugal pump is a preload and afterload dependent. And that is what you have to keep in mind. So whenever there's any change in the preload or afterload, the flow is going to change. So whatever you set the flow, what you can set is just an RPM. So that is revolution per minute. But when there's change in the preload, or afterload, there is going to be change in the flow. So if the preload increases, the flow is going to improve. So preload is directly proportional to the flow, while the afterload is inversely proportional to flow. That is what you have to keep in mind. And second thing, this pump is going to give you continuous flow, and that will not give you a pulsatile flow. The third important part of the component of the circuit is oxygenator. The one which we are using regularly is PMP oxygenator. The few points that we need to keep in mind is basically the oxygenator works with the principle of diffusion. So diffusion gradient, it moves from high to low. And remember, CO2 is highly diffusible. So you will be able to remove the CO2 very fast and rapidly, and you have to be careful about that as compared to your oxygenation. It is less resistance compared to silicone oxygenator. Initially, silicone oxygenator was the only one which was FDA approved. But now, since last few years, only PMP oxygenator which we are using for long-term ECMO. It has got a gas phase, and the gas phase is microporous. So you don't see usually a plasma leak, which was the most characteristic of the hollow fiber oxygenator, like polypropylene. But in PMP, we don't see a plasma leak. Cannula is the airway. So cannula is most important. You have to select the big size cannula, multi-stage cannula, so that you can get an adequate flow. That is an excess cannula. If you are using a small size cannula, there will be a lot of resistance and it can lead us to hemolysis. Next important point is how much is the priming volume and what you are using for priming the circuit. So as the priming volume increases, as the circuit size is big, the priming volume is big, that will increase the volume of distribution. So your all drug effects, uh, everything is affected because of the increased volume of distribution. Second thing is what you are using for priming. If you are using priming, if you are using a crystalloid for priming, then you are going to give rise to hemodilution and hypotension bradycardia can be the issue. So you have to keep that thing in your mind about the fluid, what fluid you are going to use for priming. Especially if the hemoglobin is low, that is going to be difficult. And in that scenario, you might have to use blood prime. But when you are using blood prime, again, the issue is going to be if the blood is more than 4 or 5 days old blood, then it will itself has got acidosis, hyperkalemia, hypocalcemia. So all that risk will be increased because of that. Now, if you are using that blood for the priming and then you initiate ECMO, within a minute, there are 700 or 800 ml of blood will go to the patient, adult patients, and almost around 300 goes to the pediatric patients. So in that case, it can rapid hyperkalemia can occur and that can lead to bradycardia. So you have to be mindful about that. And when you are using albumin for the prime, it will increase the risk of lung injury. So again, the lung injury can further worsen. So that's about the ECMO physiology related to the circuits. Now we come to the once we initiate ECMO, what are the things that is going to happen in the patient? So first is going to be blood surface reaction and interaction, and that is going to issue SIRS reaction. It will activate the coagulation system, and that's why we require heparination. It can induce hypoalbuminemia. It can lead to capillary leak, massive fluid resuscitation, and patient can become edema. So in first 24 to 48 hours, you might require to give lot of fluids. Usually, in all patients with once we initiate ECMO, there will be mild SIRS reaction is going to be there, but that is usually is mild. But in case when the patient is already in stage of sepsis, probably that mild reaction becomes a severe reaction. So you have to be mindful when you are going to initiate patients on ECMO with a sepsis in the background. Plus, because of the hypovolemia, again, there will be loss of the fluids. Also, many of the drugs get coated in the to the circuits, and that's why the drug effect can go down. And you have to keep this thing in mind. So when you are going to change the circuit, okay, you have to keep this in mind. So patient is already on ECMO and now say 15 days, 20 days, 35 days, and you need to change the circuit. So you have to keep this thing in mind because whenever you change the circuit, again, that is going to be new circuit. So it's going to have a new SIRS reaction. Okay. Then what happens with the circulatory system or what is going to be the effect of hemodynamics? So whenever using the patient on VV ECMO or VA ECMO, okay, there are two circulation which is going to exist. One is a ECMO circulation, second is a patient native circulation. And both of this circulation is going to have its own effect. Okay. The ECMO circulation is an artificial circulation, and that is because of the ventricular pump. And as I told you, it is going to be a continuous flow. The gas exchange is going to take place with the help of oxygenator, as well as from the lungs. This is the normal physiology, what all of us know. And this is what when we introduce ECMO to the patient. So you are draining the blood from vein. It goes to the pump that acts as an artificial heart, goes to the oxygenator that acts as an artificial lung, goes to the heat exchanger, and then goes back to the patient, either in the vein or in the artery. So now when you are talking about physiology of VA ECMO, you should understand that the blood which you drain and goes to the ECMO circuit, it remains out of heart and lung. It does not go back to the heart and lung. And from there, it goes directly to the systemic circulation. So this here, the native circulation, which is from the heart and lung, and your ECMO circulation, both run parallel to each other. And there, as the ECMO flow increases, the native circulation will decrease. And as the native circulation increases, the ECMO flow will decrease. So there's going to be vice versa. So that is, this circulation runs parallel to each other. And because of that, as you know that ECMO circulation is a continuous flow, while your your native circulation is going to have systolic and diastolic variation. So initially you can see a systolic diastolic variation, but once you put the patient on ECMO flow, and as the ECMO flow increases, your systolic and diastolic variation narrows down, and at one stage probably it might become almost a straight line. So that is what will happen when you initiate patient on VA ECMO, okay? Because you are cutting off the native circulation in that scenario, okay? And that happens with all the patients. So ECMO flow is non-pulsatile flow, and that non-pulsatile flow can have some effects on kidney. It can become there might be some amount of drop in urine output or drop in renal functions when you put the patient on non-pulsatile flow. So there was a comparison of non-pulsatile flow versus pulsatile flow when the patient is in case of on patient on ECMO. Definitely the pulsatile flow has got better compared to non-pulsatile flow. But if you see the graph here, the important part is if your flow is adequate, say more than 160 per kg, okay, then there's not much of a difference between pulsatile flow and the non-pulsatile flow, and your incidence or the risk of acidosis, oliguria, and shock remains the same. But if your flow is less, the risk of non-pulsatile flow giving rise to acidosis, oliguria, or hypoperfusion is much more as compared to pulsatile flow. So in other words, pulsatile flow, if the flow is low, it can sustain better hypoperfusion as compared to non-pulsatile flow. But most important is that if there's incidence of shock and acidotic stage, even if it's non-pulsatile flow, then in that case, you should go for a higher flow, then the risk is going to be less. So in VA ECMO, the heart is going to decrease the preload, but at the same time, it is going to increase the afterload. So that is what is very important. ECMO increases the afterload on the heart, but decreases the preload on the heart. Coronary perfusions is usually get blood from the native lungs, okay, because that is very close to the heart, and that's the ECMO flow, which is retrograde flow that does not cross the arch of aorta and cannot go to the coronaries unless the heart is at standstill. If heart is ejecting, then most of the time the coronary is going to get the blood from the heart. You will get the arterial pulse becomes narrow, as I told you. And if you see a wide pulse, it means that the heart is ejecting well and ECMO flow is low. If you see the narrow flow, it means ECMO circulation is more dominant as compared to your native circulation. What is more important is your mean arterial pressure that you need to be monitored and the pulse pressure, which is going to be important. So what are the things that can happen with VA ECMO? It can give us to cardiac stunning, or it can give us to North-South syndrome, which is now labeled as a differential hypoxia. It was previously known as North-South syndrome or Harlequin syndrome, but now, as per the ELSO definition, it is known as differential hypoxia. So cardiac stunning, anyway, we are going to discuss this in detail on the last day of this, okay, how to manage cardiac stunning. But when the pulse pressure goes down, then less than pulse pressure is less than 10, it is labeled as a cardiac stunning. Okay, it can occur for few days or few hours, and then it can revert back by itself. And there are various causes for cardiac stunning. The incidences are not very high, but if you see the ischemic heart disease patient put on ECMO, VA ECMO, the incidence is higher in that case. Again, I'm going to discuss this in more in detail in the last day. The next is differential hypoxia. So what happens is, I told you, the ECMO flow is usually a retrograde flow that is coming from your femoral artery. It is coming up in this direction, while the cardiac flow is a forward flow. So the heart, whatever is ejecting, is coming from ascending aorta to the descending aorta, while the ECMO flow is in other way around from descending aorta to ascending. So there is a competitive flow which is going to occur. If heart is not ejecting at all, the entire ECMO blood will go everywhere, including the coronaries. If heart is ejecting, then it won't allow the ECMO flow to come down. So at one particular level, there will be a competitive flow, and that is what we call as a mixing cloud. So most of the time, when you initiate ECMO, the mixing cloud takes place somewhere in the arch of aorta. So your coronaries and your right brachiocephalic is going to get blood mainly from the native circulation, while rest of the body is going to get blood from the ECMO circulation. So if your lungs are not good, then your right brachiocephalic and your native circulation, the native circulation, coronary circulation is going to be bit of hypoxic, while this is going to be hyperoxia. And that's why it is known as differential hypoxia or North-South syndrome, where you can see hyperoxic blood in the lower limb and hypoxic blood on the upper. As the heart improves, okay, this mixing cloud can go down further, and it can occur somewhere at the thoracic descending aorta or abdominal descending aorta, depending on the heart contractibility. And you will see the differential hypoxia. Okay, and this is what it can happen. Okay, so if there's no contractibility, zero contractibility, everything is ECMO flow. If heart is contracting to some extent, but the contraction is very minimum, only coronaries will get the native flow, rest of everything is ECMO flow. And as the contraction increases, the upper half and the lower half body get differentiated. Upper half will get native circulation, lower half will get ECMO circulation. But that is quite different in VV ECMO. In VV ECMO is not in parallel, but it is in series. So in VV ECMO, both the blood which goes to the ECMO circuit, it comes back to the RA. And in RA, your ECMO blood plus your native circulation blood both mix together, and then it goes to the RV, to the pulmonary circulation, and back to the left heart. And then it goes to systemic circulation. So here the circulation is in series and it's not in the parallel to each other. And that's why there's not much of a hemodynamic effects because of this particular VV ECMO. So that does not have much of a hemodynamic effect. So there's no effect on the cardiac functioning. Okay, it improves LV functions indirectly. Why? Because it improves oxygenation. So when the oxygenation is better, it can improve the the LV contractibility. There's no hemodynamic alterations. The CEP, the pulmonary artery pressures, everything will remain same. And the patient in that there is a severe pulmonary hypertension, it can give rise to RV stunning when you initiate this patient on ECMO. The problem is with the VV ECMO is going to be recirculation, as it has been told by Dr. already discussed by Dr. Pobani sir. So I'm not going in details of that. But always remember, recirculation is going to be a problem with VV ECMO, and some amount of recirculation is always accepted. If the recirculation is up to 30% is acceptable. If it goes more than 30, then you have to manage these recirculations. The next part or the last part of it is going to be gas exchange that takes place, how the gas exchange takes place. So when the patient is on ECMO, the gas exchange takes place at two levels. One at the lungs from the atmosphere, that is the native lung, and second at the tissue respiration that takes place. So always gas exchange takes place in body in two parts. So in atmospheric gas exchange, the native lungs take care of it. Okay. While the patient is on ECMO, the oxygenator also take part in the gas exchange. The principle remains the same. It is a diffusion with the pressure gradient. Okay. So this is the membrane lung, which has got a two phase. One is the blood phase and second is the gas phase. Both are being separated by a membrane, and that is what we call as a PMP membrane. So what happens usually, the gas usually passes through this membrane. It is inside the membrane, while the blood is passing outside the membrane, and the gas exchange takes place depending upon the diffusion. Okay. And that is what it takes place. As there is a PO2 is initial part is PO2 is low, so the gas exchange takes place faster and the PO2 get increased faster and the PCO2 gets removed. Okay. And that membrane exchange is going to remain the same for VV as well as VA ECMO. Okay. So blood flow to the membrane is like a pulmonary perfusion, and it is regulated by the circuit flow. So when you increase the flow, the perfusion will increase. The gas flow is like a minute ventilation or alveolar ventilation. So you are giving the gas. and it is regulated by the sweep gauge. So how much you want to give, that is can be regulated by the sweep gauge. Now within that sweep gauge, whether everything is oxygen or whether it's an oxygen or air mix, that can be decided with the help of blender. A gas phase is monitored and is limited to ensure, and gas pressure has to be less than the blood pressure, blood flow pressures. Otherwise, it can give us to increased risk of air embolisms. The CO2 exchange basically depends on the pressure gradient, the membrane diffusion characteristics, the surface area. The most important part is the sweep gas flow rate. Okay. So it depends basically on the sweep gas flow rate. Higher the sweep gas flow rate, higher is the CO2 clearance. So always whenever you want to modify anything in CO2, you have to adjust the sweep gas, because that is the only adjustable parameter. Rest of the parameters are fixed. So when you use one particular oxygenator, your membrane surface area, your gas diffusion gradient is going to remain the same. Okay. What is going to decide the variable factor is only going to be sweep gas flow, which you can adjust. Okay. And it is not dependent on the blood flow rate. So you don't require a higher blood flow for a CO2 clearance. While oxygen is different, oxygen basically depends on the blood flow rate. So if you are want to improve the oxygenation, you have to increase the blood flow rate. Okay. And it is independent of sweep gas flow. So how much is sweep gas flow? That does not change the PO2 levels. Okay. The most important part is when you are using any of the membrane lungs, all membrane lung has got their own capacity to oxygenate the blood, and that is what is called as a rated flow. So each oxygenator, depending upon its surface area, it can oxygenate a particular amount of blood. So all oxygenator has got its rated flow area, which has been mentioned by the company. So it can be a 5 liters, can be 7 liters, can be 8 liters, can be 2.3 liters, can be 800 ml. So that much of the blood it can oxygenate. If you try to put more blood than that, it won't improve the oxygenation, but at the same time, it will cause more resistance and it will increase the risk of hemolysis. So what are the problems you can get with the oxygenator? You can have a ventilation issues. That's basically takes place in the gas phase problem, and you get a membrane edema. So see, whatever the oxygen we give through the gas phase, it is basically a cold oxygenation. So it get condensed and it can cause to membrane edema. That will increase even if we are giving a sweep gas. We are not able to because there's a condensed water there. The sweep gas flow is going to be decreased, and it can lead to decrease in the CO2 clearance. You can have perfusion problems that occurs in the blood phase, where there might be small clogging or there might be a small emboli which is there in the small of the fibers, and then it decreases the flow, and that can decrease the both PO2 and PCO2 level, and your transgradient pressure is going to increase when there will be perfusion issues. Or you can have vacuum mismatch. Both there can be a problem. Some part there's a gas phase problem, some part which is blood phase problems, and that can lead to it's something like your native lungs. Okay. So native lungs, the oxygenation takes place with the help of lung recruitment, lung compliance depends on that, ventilator FiO2, mean airway pressures, while the CO2 is going to depend upon minute ventilation. And in membrane lung, the oxygenation depends upon the blood flow and what FiO2 you are going to set in the sweep gas, while and the oxygenator efficiency, and the CO2 level will depend upon the sweep gas flow. Okay. The last part of oxygenation is the transport of oxygen in the blood. That is going to remain the same for both native as well as ECMO. And that depends on the concentration gradient, the blood flow, and the hemoglobin content. So all of you know that the oxygen transport takes place mostly with the help of hemoglobin, while the carbon dioxide transport takes place mostly in the form of bicarbonate. Okay, while hemoglobin only carries 23% of CO2 transport. And this is the curve which we learned in first year in physiology, oxygen dissociation, oxygen hemoglobin dissociation curve. And initially there's a steady rise, there's a steep rise in oxygenation, and then it becomes steady rise in oxygenation. Okay. And that depends on the saturation. What is more important is your tissue respiration or tissue oxygenation, and that depends upon the oxygen consumption, the oxygen delivery, the carbon dioxide production, and the carbon dioxide removal. Okay. So remember, oxygen delivery not only depends upon the the saturation, but it depends upon the cardiac output and the hemoglobin also. So that is what is most important. It depends on two more factors. One is hemoglobin and one is cardiac output. So the oxygen delivery depends on these three factors. Okay. And if there's a different hemoglobin levels and there's a different effect of that, that can be easily seen when you see hemoglobin, if it is low, okay, with the same saturation, the oxygen content of the blood is going to be low. As compared to when they keep hemoglobin higher, say around 15, even though your saturation is going to be low, around 75, then also the oxygen, the hemoglobin content is going to be more. So that is what says that hemoglobin also determines the tissue delivery of the oxygenation. And that's why in VV ECMO, if your saturation still remains low, in spite of your high flow, in that case, the next strategy is to increase the hematocrit, and that can increase the oxygen delivery. So oxygen delivery depends, as I told you, cardiac output, hemoglobin, oxygen saturation, and the PO2 levels. Okay. And the next thing is it depends upon the consumption. How much is going to be consumption? So oxygen uptake or oxygen delivery versus oxygen consumption, and that is VO2 versus DO2. And that is what Dr. Rian also talked about. The ratio is going to be 1:5. Even if you do an exercise, the ratio comes down to 1:3. But once if patient goes into some septic condition or something, then the ratio goes down to 1:2. And in that scenario, you develop hypoxia and all problems. Okay. Otherwise, your body has got good reserve up to 5 times the reserve. Okay. So the anaerobic condition, as I told you, starts only when the this ratio becomes less than half. Okay, from 5:1, it becomes 2:1. In that kind, patient develops anaerobic condition. Otherwise, they don't develop anaerobic condition, and that can be measured with the help of your venous saturation. So venous saturation will tell you how much is the extraction taking place, and that will tell you the tissue perfusion status. Okay. So if your venous saturation comes down to less than 70, definitely all of us know that we think that patient is going to an hypoxic or hypoperfuse in state and is going into anaerobic respiration. Okay. I think these are the parameters which the oxygen consumption, how much is the oxygen consumption in normal state, and oxygen consumption can be decreased in rest, paralysis, and in case of hypothermia, the consumption decreases, while it can increase with any kind of muscular activity, infection, hyperthermia, increased level of catecholamines, or hypothyroidisms. Okay. And I think I already discussed about this, the ratio, the oxygen consumption versus oxygen delivery ratio. That is important. You should keep that in mind. Okay. The next part is CO2 removal. It usually takes place via lung in the native lungs, okay, but it may be limited because of the depends on the minute ventilation. In membrane oxygenator, it's very efficient. It's highly explosive, diffusible gas, but you have to be mindful about excessive removal of CO2. If you correct CO2 level rapidly, then it will increase the risk of bleeding in this patient. So you have to be very bleeding in the brain. So it can give some neurological complications. So you have to be very mindful while correcting the CO2, especially in patients with respiratory ECMO. When the patient is having a CO2 which is more than 60. So many times we initiate VV ECMO with a PCO of around 150, 120, 130. And if you rapidly correct it, it can give us to some neurological issues, and you have to be mindful about that. The recommended correction of CO2 should not be more than 14 mm of Hg per hour. So you have to get it down from 110 to 40 in 5 to 6 hours, not in 1 hour. Okay. So the last part is the take-home message is circulatory reactions is what we call as a surge reaction. Remember, the pump is centrifugal pump, so it is going to be dependent on preload and afterload. Oxygenator is PMP oxygenator, so we are not much worried about the plasma leak in this oxygenator. There is a dual circulation that takes place in VA and VV both, but in VA ECMO, the dual circulation is going to be parallel to each other, and that's why there's a lot of hemodynamic changes. In VV ECMO, it is going to be in series, so there's no direct hemodynamic changes that will take place. But you have to be mindful in case of VV ECMO about the cardiac stunning and differential hypoxia. In VV ECMO, you have to be mindful about the recirculation. Okay. Always remember, delivery is 5 times the consumption, and delivery depends on the cardiac output, hemoglobin, the SpO2 and PO2 levels and not only on the saturation. Thank you. Any questions? I'll be happy to answer.